America's favorite video series, don't fact check this, is now a podcast. In Collaborative Corner, Dr. Mark Blumenstein breaks down important issues in collaborative eye care. Listen to each new episode starting in January as he reviews the optometrist's role in managing a patient's eye care journey. Tune in through your preferred podcast player.
As much as we've learned about ocular surface disease, there is still so much yet to be discovered. The good news is, this creates a world of opportunity for eye care providers.
The goal of this podcast is to better understand this chronic and complex condition and keep you up to date on the advances being made in its diagnosis and treatment. So let's get to the point. Welcome to another episode of the To The Point podcast. My name is Jackie Garlich, and I'm joined by my co-host, Jessilin Quint. Hello, Jessilin. Good evening.
Hello, Jackie, and hello to all of our listeners. I don't know about you guys, but I am loving this extra sunlight and this vitamin D. It makes a world of difference for my patients, for me. It's great.
It does. And way to bring up vitamin D and needing that from a dry eye perspective. So really way to tie it all in, Jessilin. Yes, I also love the extra sunlight.
That's true. But with vitamins, I mean, what better, guest do we have on today's episode than somebody who is definitely an expert, I feel like, in all things vitamins, but especially with the ocular surface. So today we have Dr. Kaleb Abbott, who is just a real total rock star. Like, if you don't know him, you should, because he is a wealth of information, knowledge. He's all over the place. I mean, I feel like you can't go anywhere without seeing his name somewhere, whether it's an article or on, the speaking list. But he's an optometrist and he's an assistant professor of ophthalmology at the University Colorado School of Medicine, where he does a lot of different complex ocular surface conditions, participates in clinical trials, and a lot of research related to these different ocular surface conditions. He's served as vice president for the Ocular Wellness and Nutrition Society, so go Vitamins. He also has some podcast experience with the American Academy of Optometry Foundation. And really cool fun fact, last year for 2024, he had one of the most read top articles centered on vitamin A, which we're definitely going to pick his brain about, for Modern Optometry for 2024. So welcome, Kaleb. We're so glad you're here.
Welcome.
Thank you for having me. I had no idea that anybody read that article, so that's nice to hear.
It was number 2. Jessilin, you were number 1. I'm in the presence of greatness here. I have the top 2 most read articles. Jessilin, I think yours was IPL and Kaleb, yours is on vitamin A.
Oh, and fantastic.
It was really good. I read this article and I said to Jessilin, we need to talk to Kaleb. We both had talked about you previously on the side, and I was like, what a great guest. I feel like vitamin A is a topic that is not talked about nearly as much from an ocular surface disease perspective. And being such a well-read article that you had, that tells us that we need to learn more about it. So I'm excited to talk to you more about vitamin A. You can teach me all about it and why we should be caring more about it, or why we should care for the ocular surface. So thank you for being here.
Of course. Thanks for the invitation.
Why don't you start us off a little bit with just the role of vitamin A and its role on the ocular surface. Tell us a little bit more about that.
Yeah, so vitamin A is a fat-soluble vitamin. It does a whole lot of different things systemically, but also ocularly as well. So it supports immunity, growth and development, factors in with gene transcription, cell differentiation and proliferation. It affects the corneal and conjunctival cell health, and also mucous membrane integrity. When we think about vitamin A, it's actually not synthesized very well in the body. So we require vitamin A to actually be obtained through dietary sources. So we can get it through both plants and animals. Whenever it's consumed via plant sources, it's coming through things like carrots and sweet potatoes, spinach and kale. And we're actually consuming provitamin A, so actually a pre-vitamin A that's really in a carotenoid type form, like beta carotene, that then gets converted into a more active vitamin A. But then we can also consume vitamin A derivatives through animal-based products. So things like dairy, so milk, cheese, and butter, eggs, fish, and also meats. And that's actually consumed in terms of retinoids, which are really the more active forms of vitamin A. And that's really what is impacting our eyes and also our systemic health.
I incorrectly, I think associate vitamin A and goblet cell health. And really, where are we seeing vitamin A produced in the ocular surface? It's a lacrimal gland, right? It's not actually anything to do with goblet cells. Am I wrong about that?
Well, you're totally right in the fact that it affects goblet cells a lot, but it's not produced by the goblet cells. So it is actually produced by the lacrimal gland. So the lacrimal gland is storing vitamin A in the vitamin A derivative of a retinol ester. But then the lacrimal gland converts those retinol esters to retinols and then secretes those retinols into the aqueous portion of the tear film. So your ocular surface is actually constantly coated with fluid tears that are containing retinol. But then the retinol is actually taken up into the epithelial cells of the cornea and the conjunctiva, and also in the goblet cells, like you were speaking of. And then from there, it's converted to retinols, and then eventually to retinoic acid. And then the retinoic acid is what is actually impacting the ocular surface in our dry eye patients.
It's so wild to me because I feel like with vitamin A, we need it, right? Like it has so many important roles, definitely on the ocular surface. But then at the same time, too much of, I guess, any good thing, right, can kind of cause some complications. When you're talking about this with patients, and maybe maybe not a lot of our patients are vitamin A deficient, or maybe they are, but how do you start to kind of have this conversation to patients about kind of explaining like both the good things and the not good things about vitamin A, and how do you balance that out as a clinician?
Yeah, I think vitamin A is probably one of the most confusing of all the topics to talk about with patients, and also probably one of the most confusing vitamins because there are certainly components and derivatives of vitamin A that are beneficial, then also parts that can be harmful. So when we talk about the beneficial aspects of vitamin A, it's going to help with the kind of maintain an ocular surface equilibrium. So it helps the corneal and the conjunctival cells with things like wound healing. So it'll actually prevent corneal cell apoptosis. It can increase hyaluronic acid production by the corneal epithelial cells. It helps accelerate healing after an injury. It protects from keratinization and neovascularization. There's anti-inflammatory components. It alters things like gene expression and affects cellular differentiation and development and the function of cells. It also even impacts things like cancer development. So it'll inhibit the growth and development of different types of cancer cells. And then on the goblet cell aspect, our goblet cells actually require retinoic acid, so a strong version of vitamin A, in order to produce and secrete mucin. So without retinoic acid, your goblet cells aren't going to produce the mucin that then holds the rest of the tears onto the ocular surface. But I think where it gets really confusing is that there's tons and tons of different derivatives of vitamin A of various potencies. So the weakest is those pre-vitamin A's, so the beta carotenes. Then that can be converted to retinol esters, which is what the lacrimal gland is actually storing. Retinol esters are then converted into retinols. Then retinols are converted to retinols. And what we see is that retinols are about 10 times stronger than retinols. But then retinols are then converted to retinoic acid, which is about 100 times stronger than retinols. So you end up going from retinols to retinoic acid, and you're increasing, about 1,000 times in terms of strength. But then there's all these patients that are taking prescription grade vitamin A, so things like isotretinoins that are then 10 to 20 times stronger than retinoic acid. So where we kind of get in the weeds and where we get confused as practitioners is which vitamin A derivatives are good for our patients and which ones are bad for our patients.
One question I had about that is because, we certainly see patients that have either a history of Accutane use or using topical tretinoin around the eye. And, we hear like, okay, we do need vitamin A, but what do you tell these patients who are taking these like in much stronger concentrations, which can be a detriment to the ocular surface? We've seen that with Accutane use. We've hypothesized, and I don't know that there's any clinical studies on tretinoin use around the eye. But what are you talking about with your patients when you see that they're on these medications? What can they be doing preventatively?
Yeah, so I think first it's important to recognize that isotretinoin is a prescription version of vitamin A that's 10 to 20 times stronger than retinoic acid, which is already the most potent form of vitamin A that we actually have in our bodies. So whenever our patients are taking things like Accutane, the entire purpose of taking Accutane is to try to impact these sebaceous glands of the face. So usually what you're trying to do is treat recalcitrant acne vulgaris. So you're trying to actually get rid of acne. So in Accutane does a very, very good job at treating acne. So it'll actually reduce sebum production by up to 90% within 6 weeks, and it completely destroys a lot of sebaceous glands of the face. But the problem is that the destruction of sebaceous glands is not relegated to just the face. It also actually affects the sebaceous glands of the eyelids, which we call the meibomian glands. So it ends up dramatically impacting those meibomian glands. So it'll cause keratinization of the meibomian glands. It will actually cause acinar cell degeneration, fibrosis of the glands, atrophy of the glands. It inhibits cell proliferation, affects the epithelial cells, gene expression, causes inflammation, does all sorts of negative things to our meibomian glands that then end up causing atrophy of those glands and subsequently a lot of dry eye for our patients.
I'm always amazed at sometimes how damage can happen really quickly. Like I'm thinking back to like one patient in particular, how I saw her for, she's a young teen, right? Has some acne, saw her for her annual exam, was started on Accutane, and then saw her like less than a week later because she was just having some dry eye with it. And we scanned her meibomian glands. And just like, I feel like in a matter of a week, we had like a lot of atrophy, a lot of truncation. And so to me, that was a kind of a quick reminder of how sometimes this really high potent, drug can really kind of damage the ocular surface in a pretty quick time frame. And so, obviously there's a lot of opportunity there to educate our colleagues or educate our patients and try to be proactive and understand maybe the risks that can come with that so that no patient is left with any surprises on the back end of using Accutane.
Certainly. I think that the use of Accutane from a meibomian gland perspective is definitely concerning. So I think as practitioners, we should try to let other practitioners know that are prescribing Accutane all the effects they can have on my meibomian gland. So any patient that has pre-existing dry eye or ocular discomfort, in my opinion, really should not be using this medication. But then also, I would like to see us do a better job of actually trying to closely monitor patients on Accutane, trying to check for things like meibomian gland atrophy and dry eye, because I think the big problem here is that the morphologic changes or the anatomical changes that we see to the meibomian glands are generally considered to be irreversible. So once we end up getting atrophy and keratinization of those glands, we don't know how we can actually reverse those changes. So these patients will sometimes end up having chronic dry eye for the rest of their life, just as as a result of treating their acne.
I wonder, do you guys, I mean, there's certainly nothing written about this. How can we be, proactive for our patients that are on Accutane? But do you all suggest things like, let's do a thermal expression. Let's try to like keep these glands moving while someone's on Accutane. Like, what have you guys, encountered with that?
Yeah, I think it's difficult. I work in the adult hospital that's across the street from the children's hospital. And a lot of times the people that are being prescribed this are people in adolescence. And I actually took Accutane as a kid, and I have subsequent meibomian gland atrophy as a result of that. But I'm not seeing those patients. So I think adult hospitals and children's hospitals are sometimes quite separated. So it's a little bit harder on our end, but I think as practitioners, we just need to do a better job trying to identify patients that are using Accutane, try to do a better job, screening for those patients, or maybe even talking to the dermatologists that are in our communities and letting them know if you have a patient that you're starting on Accutane, we really should be monitoring this patient closely. So it really comes back to trying to better co-manage these patients and educate other providers and other specialties.
Aside from like the Accutane tretinoin conversation, let's say a patient is not on this and we're just talking about the value of vitamin A. This is sort of an aside, but there are some ointments that I will sometimes recommend that contain vitamin A to help improve what I think will improve the ocular surface when I prescribe these. Have you done that also? Do you find that these ointments will help if they do contain some vitamin A? What's been your experience with that?
Yeah, as far as I know, there's two ointments in the United States that contain vitamin A, and usually those ointments are containing a weak version of vitamin A. So a retinol ester, which is really the safest version of vitamin A to be using on the eye. And I think it's important for us to recognize that vitamin A in general only has positive impacts on the cornea and the conjunctiva and the goblet cells. It's just the problem is if you have too much of it or too potent amounts of it, then that can damage the meibomian glands. But when we're talking about vitamin A's that are used in ophthalmic ointments that are over the counter, usually it's a weak version of vitamin A. So I actually really like those products because in my experience, they haven't damaged the meibomian glands. But on the contrary, they've really helped the cornea with things like wound healing and actually tried to help heal some of that corneal staining. And I think it's a good way to support goblet cells if you feel like there's a deficiency in goblet cell production.
That's literally where I use that a lot, is if I see a lot of lissamine green staining on the con, just when I'm really sort of reaching more for that particular ointment. So yeah, interesting. Okay, good.
Another thing to consider, so whenever we think about vitamins, people are always talking about, are you deficient in a vitamin, or are you getting too much of a vitamin? And vitamin A is fat soluble, meaning that it is stored inside our fat cells, so there is a risk of having too much vitamin A. There's also patients that can become deficient in vitamin A, and deficiency actually remains a pretty big global issue. So we see that globally it affects about 1/3 of children worldwide and actually can lead to blindness in about 250,000 to about 500,000 children each year. However, in the United States, deficiency is exceedingly rare. So it only impacts about 0.3% of the population. And usually the people that it's impacting are those that have substance abuse problems, or they've had a GI type surgery, or have malabsorption issues and things like that. But when we see signs of deficiency, you can have patients that develop night blindness and then subsequently blindness. Systemically, they'll have kind of a dry skin or impaired wound healing, and then maybe get infections of their skin. But on the eyes, sometimes we'll see what's called like Bitot spots, which are these kind of white, frothy looking plaques on the conjunctival surface. They'll usually be located kind of where you would see a pinguecula, so kind of in the like temporal limbus type area. And you can start to get just kind of general dryness of the conjunctiva and the cornea as well. And, it can get as bad as leading to something like corneal ulcerations and things like that. But in the United States, vitamin A deficiency is really, really rare. On the flip side, getting too much of vitamin A is actually also pretty rare in the United States. Really, the exceptions to that is if you're taking a prescription medication like Accutane that ends up causing too much vitamin A and then subsequently damaging those meibomian glands. So if people are wondering if there's deficiencies, it's unlikely but possible. And if you're getting too much vitamin A, it's unlikely unless patients are then, taking prescription medications that could induce that.
I like that. Very good things to keep in mind, because sometimes when when the patient's in your chair, sometimes just deep diving further to figure out if the deficiency or too much is a possibility is definitely one to always kind of keep on our radar. I love that you're so kind of focused, especially on that nutritional aspect. I know that that's definitely an interest, and I feel like when I bring this up with my patients, it kind of naturally leads into a discussion of all these extra lifestyle factors that implement the ocular surface, and stress and sleep kind of being a big one. And so do you tackle that with patients, or can you comment a little bit on how sleep and stress can really kind of impact mental health, ocular surface? It's all tied in. What's been your kind of take on that?
Yeah, I'm very interested in all sorts of different things that impact, our patients' discomfort. And I kind of see my job as treating eye pain and eye discomfort. So I try to do a good job trying to understand all the different factors that could impact my patients. And I think we're starting to realize that the risk factors that we once thought were really pertinent for dry eye are actually not that correlated with our patients' dry eye symptoms. I mean, we were taught in school that if a patient is taking antihistamines or antidepressants or anxiolytics or things like that, it decreases lacrimal gland secretions and then subsequently causes dry eye in our patients. But I think the problem is we're starting to realize that that's not that correlated with patient symptoms. And in the end, we're trying to make our patients' eyes actually feel better when we're treating their dry eye. So when we look at what conditions are actually strongly correlated with dry eye symptoms, we actually see things like anxiety, depression, sleep disorders, like you were mentioning, chronic pain syndromes, things like migraines, small fiber neuropathies, fibromyalgia, and things like that. We see a bunch of conditions that are affecting the nervous system, the peripheral nervous system, and the central nervous system that are affecting pain perception and pain processing centers of the brain. So I think we're starting to get a better idea um, of kind of all the things that are actually impacting our patients. And just because a medication, quote unquote, dries out the eye, does not mean that it's actually going to result in more dry eye symptoms. And even on the flip side to that, we actually see that treatment of anxiety and depression, which we know can increase pain perception, if you end up treating it, it actually improves the success of our dry eye treatments. Probably because you're actually modulating the pain perception and the nervous system in general. So we were taught in school patients that are using these medications is going to dry out the eyes, and perhaps it does. Maybe it does decrease lacrimal gland secretions, but it actually impacts the corneal nerves enough and affects the nervous system enough that actually their symptoms are improving. And this is something that I really hope that providers start to a little bit better understand, is the difference between the eyes being dry and actually experiencing dry eye symptoms.
That is a great connection. Usually when I'm seeing a dry eye patient, there's never just one thing, right? It's never one thing that's causing the problem. I go, wouldn't that be great if it was just this one thing we could tackle and then everything would feel better? So it really is treating the whole person, and it goes from mental health status to environment. Sometimes it's like I had a patient actually the other day who said, I had this fan that was right over my desk and I just moved my desk over and now I'm feeling a lot better. You're just like, oh God, okay,
There's
well,
so
like,
many things.
you're like, oh, that's great. But, to your point, I mean, certainly there's medications that can dry out, quote unquote, the eyes. And maybe that's a small piece to the bigger puzzle. And it's really trying to unpack what that bigger, all the pieces of the puzzle to really kind of fix that person. Do you have relationships with therapists, or do you find yourself referring for patients, or are you finding patients are on therapies and working on, sort of if they have any mental health, issues they're working through?
Yeah, I think we have to do a better job, as you were saying, kind of understanding the patient in general and all the things that could be impacting their dry eye journey. So I actually have a very low threshold to refer patients to, psychiatrists and psychologists to try to help with the anxiety and depression portion that I feel like is contributing to their dry eye, because the evidence shows that it can be. I mean, Jessilin was mentioning earlier the impact of sleep on dry eye, and this is something that has really been a major focus of mine in recent years, is trying to understand, how my patients' sleep is impacting the symptoms that they're experiencing with their dry eye. And we see that there's tons and tons of evidence that show that patients with poor sleep have dry eye. But then on the flip side, we see that patients with dry eye have poor sleep. And so I think kind of the question is, which one came first? Does poor sleep cause dry eye, or does dry eye cause poor sleep? And I think that really, I've spent a while trying to better understand this, and I think that the evidence points to both. So we see that patients that are sleep deprived end up having reduced lacrimal gland secretions, increased tear osmolarity, but they also have increased corneal sensitivity. So their eyes are actually becoming more dry, and they're feeling that dryness much more, and that results in more dry eye symptoms. But then on the flip side, we see studies that tell us that patients that have dry eye have more irritation at nighttime. They have longer sleep latency, so it takes them more time to fall asleep at night. It can also wake them up in the middle of the night whenever their eyes become painful or irritated. And there's a really great study out of Japan from Miyake et al. That shows that if you take new dry eye patients and you put them on therapy, it can actually improve their sleep duration and their sleep quality. So trying to get a better idea of all these lifestyle factors that are impacting our patients, I think, is really critical, because we can prescribe all these different medications out there. We can do different procedures out there. But I found with some of my patients, if they're still sleeping 3 or 4 hours a night, you're not going to control their symptoms. So you have to kind of delve deeper with these patients and figure out kind of holistically, what is impacting their dry eye and their symptoms.
This is where like a handout really comes comes in handy. So I have a whole handout on additional tips for success is what I call it. I've talked about this before, but it's so hard to get to all of it. And your patient, as we know, can't remember or retain all the things that you're asking or telling them. So I find, and myself, I can forget to ask some of these things or even talk about sleep cycle or sleep, in the exam room when I'm first seeing a patient. So handouts are helpful. I'm sure you guys have your own.
Oh yeah, that's a great idea. We only have so much time with our patients also.
Very true. And sometimes repetition is key too, right? Sometimes if they cover it, they read it, they go through a series of dry eye treatments and they're like, why am I still having symptoms, right? We've done everything. Why am I still having symptoms? And assuming there's not a masquerader there, it's like, well, let's look at your lifestyle impacts, and things sometimes that I feel like are common sense to us because we're in the field, right? Like the fan or the vent blowing on them or sleep quality. Sometimes we don't, those are not kind of quote unquote common sense things for our patients, right? Because they're just not in that field. So handouts are great. And I always like to just have a reminder of, okay, put myself in my patient's shoes, somebody who knows nothing about eyes or any of that and doesn't always see that connection. And part of our role is to kind of help them make that connection for them so that it comes full circle and, a greater understanding that dry eye is very multifactorial.
I love that. Yeah, you're totally right when you say things that are obvious to us are not obvious to our patients. I mean, I had a patient the other day that said, my eyes kill me every time I drive to the mountains. And I mean, and I spent forever trying to unpack why that would be and high elevation and this and that. And what are you doing in the mountains and blah, blah, blah. And then finally, at the end of the exam, I asked him, have you pointed your air vents not directly at your eyes? And he was like, oh, I hadn't thought about that. And I was like, man, that really should have been the first thing that I asked, but to me it was common sense, so I didn't ask it at first.
Yeah, I know but you know what, also sometimes patients, I'll sometimes say, what do you think is making this worse? Is there something that you think is making it worse? And you can almost kind of get guided into an air vent situation, and then they can sort of figure it out. But
that's a good idea.
I like it. Well, this wouldn't be a to the point podcast if we didn't ask you what your life lens is. So, drop some knowledge on us, share us what's been a game changer for you.
So there was a period of time 6 months ago that I had 3 kids under the age of 4. I now have a 4-year-old and twin 6-month-olds. And what has helped me the most, the life lens, is having an au pair. So we got an au pair from France that started November 1st. And yeah, she lives with us now and helps watch the kiddos, but also ends up giving me and my wife some time so we can kind of, have a flexible schedule and go on date nights and end up kind of getting away a little bit. So she's been helpful with the kids, and we've kind of incorporated her into the family in general. And that's been the biggest help for us in our lives recently.
That's great. Congrats to you on these 2 new ones that you added to the mix. I mean, you guys are both very busy. You and your wife, you guys have both, you do a lot of speaking engagements. So it's a lot to keep up with. And I think the only way you can do stuff like that is if you have help. So I'm glad you're doing it. We had another guest who said that they got a cleaning lady, and that was a total game changer for them. And I'm like, you know what? We can't do it all. So you gotta get some help sometimes,
Yeah.
Good for you.
It's painful to talk about how sleep impacts dry eye, knowing I'm not getting very much sleep these days.
So true. Well, Kaleb, thank you so much for being here. If our listeners wanted to connect with you or, send you a message or just kind of, look you up in a way, how could they find you?
Oh, yeah. I would say my email address, KalebAbbottOD@gmail.com, or you can find me on LinkedIn. I'm typically pretty quick to respond.
Okay. Thank you so much for coming and spending your very busy evening with us. Thank you for being here.
Thank you for having me. I appreciate it.